Hello, everyone, and welcome back to the MI Mental podcast, the Doctors in Court edition. My name is Dr. Sabine Fonderson. I'm a general practitioner, and today I have another interesting case to dive into. It's about a medical doctor who was brought to court after being accused of neglecting a patient's care. This case brings up some pretty interesting discussions on patient safety, autonomy, and mental health care in a clinical setting. So while the case is real, the names, of course, are not. Let's break this down step by step so you can really understand how things unfolded. We're in 2006, and the patient is called Mrs. Green. She's a long-term patient at a psychiatric facility, and she's been under the care for a history of depression, self-harm, and post-traumatic stress disorder, or PTSD. At the end of the year, December 2006, Mrs. Green was transferred to a new care unit where she was put under the Bed on Request program. It's a voluntary system allowing patients to check in when they feel they couldn't cope at home. Throughout the year in 2007, Mrs. Green came in several times when her mental state deteriorated, particularly when she was feeling overwhelmed by her emotions. In October of 2007, Mrs. Green was admitted for yet another crisis intervention. This time, she came in after an especially tough night and was placed under the care of the doctor, Mr. Blue. The next morning, Mrs. Green was found self-harming in her room, and despite plans to discharge her that day, her behavior worsened, and it led to a crisis involving a medication overdose of diazepam. So what's the issue here? Mrs. Green's family decided to file a complaint after she overdosed. Their argument was pretty straightforward. They believed that the doctor, Mr. Blue, had failed to safeguard Mrs. and that his actions or inaction led directly to the overdose. So let me break down the case. The family argued that Dr. Blue didn't properly supervise Mrs. Green, especially considering her known history of suicidal tendencies and self-harming behaviors. They pointed out that she had diazepam on her and he didn't remove it when he should have. The family also believed that Dr. Blue didn't take Mrs. Green's escalating distress seriously enough. Her behaviors and signs were something that needed more immediate intervention. And the final issue that the family had was that they were also concerned about Dr. Blue's not communicating well with the other parts of the care team, which might have helped prevent this incident. So let's talk about what Dr. Blue, his defense, said. Well, Dr. Blue didn't exactly deny that mistakes were made, but his defense was more about the challenges of managing a patient like Mrs. Green. And here's what he argued. Dr. Blue emphasized that Mrs. Green's admission was voluntary under the BOR, the Bed on Request program, and as such, there was a limit to the control the staff had over her personal items, like diazepam. Since she was voluntarily admitted, they argued it wasn't a fully locked down situation. Dr. Blue also claimed that he followed the standard procedures for monitoring patients and that he was checking on Mrs. Green regularly. He pointed out that her emotional state was unpredictable, and while her distress was clear, she hadn't expressed suicidal intent directly to him. And Dr. Blue also noted that the decisions regarding medication and access to substances like diazepam were ultimately the responsibility of the psychiatrist who was overseeing Mrs. Green's care, and his role was more focused on general duties. Now let's take a minute to clarify some of the medical terms that are central to this case, especially since this touches on mental health and personality disorders. Post-traumatic stress disorder, or PTSD. PTSD is a mental health condition triggered by experiencing or witnessing traumatic events. It's characterized by flashbacks, nightmares, and severe anxiety. And Mrs. Green had PTSD, and that history played a huge role in her mental health and treatment during this case. Borderline personality disorder, BPD. This is a disorder marked by instability in mood, self-image, and relationships. And people with borderline personality disorder often struggle with emotional regulation, impulsivity, and the fear of abandonment. According to an article by Lescheving and his colleagues in 2024, borderline personality disorder can cause intense interpersonal issues, impulsive actions, and recurrent self-harm, all of which Mrs. Green exhibited during her time at the facility. Diazepam, or Valium, is a medication commonly used to treat anxiety and muscle spasms, but is also known for its addictive properties and sedative effects. An overdose of diazepam can lead to life-threatening consequences, particularly in a patient with a history of self-harm, like Mrs. Green. So after all these evidence, the court ruled that Dr. Blue had indeed failed in a couple of key areas. They acknowledged that the voluntary nature of Mrs. Green's admission meant that there was a level of personal responsibility she retained. However, given her known history of self-harm and psychiatric vulnerability, Dr. Blue should have taken additional precautions. And the court found Dr. Blue guilty of negligence for not securing the diazepam and for failing to respond appropriately to Mrs. Green's growing emotional instability. However, because the case involved complex factors like Mrs. Green's personality disorder and the ambiguity of a voluntary admission, the court decided to issue a warning rather than a harsher penalty. Now, let me pose a couple of questions for you, the listeners. How far should a healthcare provider go in taking responsibility for a patient's safety when the patient has voluntarily control over their actions? Well, in cases like this, the balance is tricky. Yes, the patient has autonomy, but the healthcare provider is still responsible for ensuring that patient is safe from themselves, especially if there's a known history of self-harm or suicidal ideation. And it's really about balancing autonomy with protection. In mental health care, how do we strike a balance between respecting a patient's autonomy and ensuring their safety? This is one of the huge dilemmas in this case. We need to respect a patient's autonomy, but if their mental health history suggests they are a danger to themselves, healthcare providers need to have systems in place to intervene without infringing on their rights. And I think more training and better communication across the care team can help prevent situations like this from escalating. I want to take a few minutes now to dive deeper into a comprehensive review article I recently read titled Borderline Personality Disorder, Comprehensive Review of Diagnosis and Clinical Management by Ring and his colleagues in 2024. This article offers an exhaustive look at the diagnosis, clinical presentation, and treatment of borderline personality disorder. It's a topic that's especially relevant to today's discussion on the patient care, mental health challenges, and how clinicians approach complex cases like the one we talked about earlier. Now, the article emphasizes that borderline personality disorder is one of the most challenging and debilitating psychiatric disorder. It affects 1 to 2% of the general population and is more prevalent in women than in men. Borderline personality disorder is a pervasive pattern of instability in interpersonal relationships, self-image, and emotions, often leading to impulsivity and self-destructive behaviors such as self-harm and suicidal tendencies. The article stresses the importance of early diagnosis and appropriate treatment, as borderline personality disorder is frequently associated with other psychiatric disorders like depression, substance abuse, and post-traumatic stress disorder, which complicates diagnosis and care. The review covers the diagnostic criteria based on the DSM-5 and provides an in-depth look at how borderline personality disorder is often diagnosed in clinical settings. The diagnosis is based on 5 or more symptoms, which include a frantic effort to avoid abandonment, whether real or imagined, unstable and intense interpersonal relationships characterized by extremes of idealization and devaluation, identity disturbance such as a markedly and persistently unstable self-image or sense of self, impulsivity in at least 2 areas that are potentially self-damaging, for example, spending, sexual activity, or substance abuse. There's also recurrent suicidal behavior, gestures or threats, or even self-mutilating behavior. An affective instability due to a marked reactivity of mood, for example, intense episodic dysphoria, irritability, or anxiety. The condition is also characterized by chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger. And lastly, there's transient stress-related paranoid ideation or severe dissociative symptoms. And the authors explain that while the diagnostic criteria are clear, the heterogeneity of borderline personality disorder symptoms means that diagnosis is not always straightforward, and the disorder frequently overlaps with other psychiatric conditions, complicating the picture. The article provides a detailed analysis of the clinical features of borderline personality disorder and explains how these features manifest differently in patients. The most prominent symptoms often include mood swings, emotional dysregulation, and impulsive behaviors. The emotional instability leads to dramatic shifts in interpersonal relationships, where individuals with borderline personality disorder often oscillate between extreme affection and hatred towards others. The author stressed that self-harming behaviors such as cutting or burning oneself are not uncommon and can be triggered by real or perceived abandonment or rejection. And these behaviors are often a coping mechanism for emotional pain and a way for individuals to manage overwhelming emotions. The authors delve into the neurobiological and psychological factors that may contribute to borderline personality disorder. And research suggests that genetic predispositions, early childhood trauma, and attachment disturbances are often factors in the development of the disorder. And the review also highlights how emotional dysregulation in borderline personality disorder could be linked to dysfunction in the prefrontal cortex and the amygdala, which regulate emotions and social behavior. And from a psychological standpoint, attachment theory plays a crucial role in understanding the disorder. And the review discusses how insecure attachment patterns during childhood, such as neglect or inconsistent caregiving, can lead to difficulties in emotional regulation and interpersonal relationships later in life. And one of the most valuable sections of the article is its extensive review for treatment options in borderline personality disorder. The authors recommend dialectical behavioral therapy, DBT, as a gold standard for treatment. DBT is a form of cognitive behavioral therapy, CBT, developed by Marsha Linehan, which focuses on helping patients develop skills in 4 key areas: mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. And DBT has shown great success in reducing self-harm and improving interpersonal functioning in patients with borderline personality disorder. And this article also covers other forms of therapy such as mentalization-based treatment, MBT, which helps individuals with borderline personality disorder better understand and interpret their emotions and the emotions of others, and transference-focused psychotherapy, TFP, which helps patients explore and understand their relationships and emotional responses. In addition to therapy, pharmacotherapy can be used to address co-occurring disorders such as depression, anxiety, and impulsivity. However, the authors emphasize that medication should never be the primary treatment for borderline personality disorder and should always be considered adjunctive to psychotherapy. But despite the effectiveness of DBT and other therapies, the authors acknowledge the challenges in treating borderline personality disorder. And persons with this disorder often experience high rates of treatment dropout, non-compliance, and therapist burnout. And one of the key barriers to successful treatment is the patient's inability to tolerate distress and their tendency to push therapists away when they feel abandoned. However, the article also points to positive prognostic factors such as early intervention, the presence of strong family support, and a therapeutic alliance between the patient and their clinician. When these factors are in place, patients with borderline personality disorder can experience significant improvement in their emotional regulation, their self-esteem, and their interpersonal relationships. And the article concludes with a discussion on the clinical implications of borderline personality disorder treatment and the importance of developing more integrated care models. The authors recommend a multidisciplinary approach that involves psychiatrists, therapists, social workers, family members working together to ensure patients receive comprehensive and coordinated care. And finally, they call for more research into the neurobiological and genetic aspects of borderline personality disorder to better understand its etiology and to develop more targeted treatment options. And the authors also suggest that improving early detection and public awareness of borderline personality disorder could lead to better long-term outcomes for individuals suffering from this condition. That's a pretty robust overview of this article. It provides a deep dive into borderline personality disorder and offers valuable insights for those of us working in the medical profession. The complex nature of this disorder means that both diagnosis and treatment are ongoing challenges, but there's hope. With the right combination of therapy and support, and if you're interested in reading more, I highly recommend checking out the article completely. Thank you so much again for tuning into this episode of the MI Mental podcast, Doctors in Court edition. And this case really got me thinking about the fine line between patient autonomy and the responsibility of healthcare providers to intervene when necessary. Again, I would love to hear your thoughts. Do you think the system did enough, or could things have done differently? And don't forget to subscribe and share your feedback if you want to hear more.